So today, the way I organize my presentation is based on a timeline, and it's an approximation of the reality. And also to make it easier for the narrative, I order it, but there is some overlap between different systems. So originally, the idea was that tinnitus was a pure ear problem, but based on basic research and clinical findings, neuroscientists got more and more interested in tinnitus and how the brain is involved in tinnitus. And the research started mainly with looking into the auditory system. Now, about 30 years ago, Rodolfo Linus introduced a model which was called the Thalamuscorticos Rhythmia model that tried to explain several chronic, severe neurological and neuropsychiatric disorders, including Parkinson's disease, tinnitus, neurogenic pain, and depression. And when he basically collected MEG data and compared the MEG data of those indications with a control group, what he saw was actually that there was a difference at specific frequency bands within the EEG. And when he did a power spectrum analysis, and as you can see on the figure on the left side, what he saw was that there actually was reduced alpha activity that would go together with increased theta activity that was associated with increased beta and gamma activity. Now, the way he explained it was that actually the reason why we saw a reduction of alpha activity that goes together with increase of theta activity is because there was deafferentation. And tinnitus, it could be hearing loss, or it could be an obstruction down the auditory pathway that goes together with the negative symptom. And that would go together with theta activity. Because there was theta activity, this would basically set up a disinhibition mechanism that then would create a positive symptom, which was the tinnitus. That was reflected by gamma frequency. Now, if you look at the figure below, actually what you normally see in when you do an EEG in healthy subjects is that at rest, you will see a lot of alpha activity in the back of the head, as well as in temporal lobe. Now, because there is a differentiation, the assumption is that alpha activity will slow down to theta activity and that you will get a halo of gamma activity because there's no lateral inhibition anymore, which is normally induced by alpha activity. And that this activity is actually that is creating the tinnitus. Now, although this was a model, and although in his data there was only one tinnitus patient, people got interested in this model and started to basically test some of the predictions that were related to this model. And the group of the Redder actually showed that 10 years later, that indeed tinnitus is reflected by an increased gamma activity in tinnitus patients in comparison to controls in the auditory cortex, and that actually the activity in the auditory cortex correlates with how loud people perceive their tinnitus. This was also confirmed by looking at bolt activity with fMRI, showing that there is increased bolt activity in the auditory cortex. Now, Nathan Weiss' group replicated those results and also showed that indeed there is an increase in theta activity that goes together with a decrease in alpha activity, and that there is actually a correlation between alpha power and gamma power, but that the relationship is inversely related, meaning that the less alpha power, the more gamma power you will see in the temporal area, probably the auditory cortex. All of this data fit with the prediction of the Thalamuscorticos Rhythmia model. Now, we then continued to do research in patients that were implanted with a cortical electrode overlapping the auditory cortex, where we looked where you have different contact points, and specifically the contact point that was overlapping the bolt activity in tinnitus patients. When we recorded from that specific electrode, what we saw was indeed what the Thalamuscorticos Rhythmia model was predicting, that there was an increase in theta activity, and that when we stimulated that specific electrode, where there was that hyperactivity, that we could see a reduction of the theta activity, suggesting that there's a causal relationship between the theta activity and as well as the gamma activity and tinnitus. Now, what was intriguing is that not all people responded to the treatment, and we did a post hoc analysis and start to compare people that responded to this treatment in comparison to people that did not respond to the treatment. And what was intriguing is actually that we didn't see any changes in the auditory cortex, but that actually the changes were observed, again, for the gamma frequency band, in the parahippocampal area, not the auditory cortex, but that in addition to the parahippocampus, there was increased communication between the auditory cortex and the parahippocampus for the theta frequency for people that responded to the treatment. This is suggesting that maybe the auditory cortex is an epiphenomenon and that actually the core of the tinnitus percept or the tinnitus loudness is in the parahippocampus. Now, it could also be that this was an accidental finding, so we need to have a replication of these findings. Now, when we did a meta-analysis based on PET data, again, the parahippocampus was showing up. And digging into the literature, the group of Regensburg actually showed that there are structural changes based on voxel morphometry in the hippocampus extending to the parahippocampus and tinnitus patient in comparison to controls. So this is suggesting that there actually might be something in the parahippocampus. The final confirmation was actually brought by Sidley's group in patients that had epilepsy and were implanted with an electrode that was overlapping also the parahippocampus. And when he did intracranial recordings, what he did see was indeed that there were changes in the parahippocampus and that he saw changes in the lower frequencies, so the theta delta frequency band, that interacted with the middle frequencies, which is the alpha frequency band, that goes together with high frequency activity in the gamma band in tinnitus patients. So this is actually confirmation that indeed the parahippocampus might play an important role. But why is it that in some patients we see these findings and in other patients we do not see these findings? So we did a follow-up research and we start to compare people that have mild hearing loss, that have tinnitus in comparison to the control group, and people that have severe hearing loss and that have tinnitus in comparison to the control group. And what was intriguing is that if we compare the mild hearing loss tinnitus patient with control, we indeed see increased activity in the auditory cortex for the gamma frequency band. But that for severe hearing loss tinnitus patient, we saw that it's actually not the auditory cortex, but the parahippocampus that was lighting up, also in the gamma frequency band. In a follow-up analysis, we correlated the hearing loss with the whole brain. And actually what we do see is that hearing loss correlated with theta. Remember that the theta was reflected by the Thalamuscorticos Rhythmia model as a negative symptom. And what we do see is that hearing loss has a positive correlation with activity in the parahippocampus for theta activity. We used two types of methods. We looked at the mean hearing loss and we looked at the range of the hearing loss. And indeed, we saw that for both measurements, there was a correlation with the parahippocampus. So the more hearing loss people have, the more activity change you see in the parahippocampus, specifically for the theta. But in addition, we also did a region of interest analysis, looking at the gamma frequency band, looking at both the auditory cortex and the parahippocampus. And what we do see was that there was a positive correlation for tinnitus loudness in the parahippocampus for people that had tinnitus patients that had severe hearing loss, but that for patients that had mild hearing loss, the tinnitus loudness correlated with the auditory cortex. So it seems that the auditory cortex and both the parahippocampus play an important role in tinnitus depending on the amount of hearing loss. Now, around the same time, people got also interested in more frontal areas and if they were involved in tinnitus. What we do know is that about 25% of the people that have tinnitus are very distressed and are really suffering about their tinnitus. And Jastreboff already in 2003 introduced a model showing that there might be frontal areas as well as the limbic system that is involved in tinnitus. So that was very intriguing. So we start looking into that. And we compared tinnitus patients that had the same amount of loudness as well as the same amount of hearing loss. And we compared people that had high distress in comparison to people that had low distress. And what we saw was that actually we saw increased alpha activity in the subgenual anterior cingulate cortex. Now the subgenual anterior cingulate cortex is actually an area that is well known in the depression literature and is actually a target for deep brain stimulation. There's a whole literature mainly driven by Helen Mayberg that shows that this is an important target that can help people with major depression When we compared the stress tinnitus patient with the health control group, we also saw the dorsal anterior cingulate cortex showing up for the beta frequency band. Now, we know that the dorsal anterior cingulate cortex is important in attention, and it could be that basically patients that are distressed by the tinnitus focus more on their tinnitus. These findings were confirmed by fMRI. There's showing that again, the dorsal anterior cingulate cortex as well as the insula and the general anterior cingulate cortex correlated with how much tinnitus distress they have. But how are the two systems actually related, the tinnitus loudness system and the distress system? Well, in a follow-up study, we did an independent component analysis, which is a specific technique that you can apply. And what we saw was actually that we could see 6 networks in the brain that are related to tinnitus. 4 of them were related to how distressed the patients are, and 2 of them were related to how loud they perceive their tinnitus. The 2 components are basically in this figure shown by the light blue color, and the purple are basically the distress networks involved in it. Now, in a follow-up analysis, we then compare people that had tinnitus, but basically were not distressed about their tinnitus. Those were grade 1. And we compare them to grade 2s that had moderate stress, grade 3 that had severe stress, and then people that basically were saying that their tinnitus was unbearable. When we compare all these groups, what we do saw was actually that at some point when they are really suffering from their tinnitus, that these 2 networks, the distress system and the loudness system, start to communicate at a very specific frequency. And that the 2 areas actually that were communicating were the parahippocampus, and remember the parahippocampus was already introduced in the loudness, related to loudness, and the subgenual anterior cingulate cortex, which is known as a target for mood. So this was quite intriguing that actually when people suffer from their tinnitus, all of a sudden 2 networks that seem to be unrelated start to communicate. Now, around the same time, there was another model introduced by Rorschach, which is called the canceling system or the noise canceling system. Now, Rorschach had a completely different approach. He basically indicated that the ventromedial prefrontal cortex extended to the pregeneral anterior cingulate cortex might be important also in tinnitus, and that the specific function of those areas are actually to break the tinnitus or to basically cancel the tinnitus. And it's known that the ventromedial prefrontal cortex and the pregeneral anterior cingulate cortex are actually part of a descending pathway in pain, and if that system doesn't work that well, that it's very likely that people will have bodily spread chronic pain. So it could be that it's also involved in tinnitus. Now, he tested the model in a follow-up paper showing that indeed there are structural changes in the ventromedial prefrontal cortex extending to the pregeneral anterior cingulate cortex in tinnitus patients in comparison to control subjects. But people were a little bit puzzled. Why is it that basically that area is showing up and other people did not see it? So we did a follow-up study actually comparing people that have no hearing loss but do have tinnitus and people that have hearing loss and have no tinnitus. Now, when you compare patients that have hearing loss versus no hearing loss and no tinnitus, what we saw was actually changes in the ventromedial prefrontal cortex extended to the pregeneral anterior cingulate cortex for alpha. And basically people that had hearing loss but did not perceive tinnitus, there was an increased alpha activity in that specific spot. Now, when we compared tinnitus patients that have no hearing loss but do have tinnitus in comparison to people that have no hearing loss and no tinnitus, we saw again that same area, but now it was not at the alpha frequency band, but in the theta frequency band, and there was increased theta activity in that specific area. So this was quite intriguing. We continued to analyze our data, and we showed that actually the ratio between alpha and theta activity was changing, and that the more theta and the less alpha activity we saw in the pregeneral anterior cingulate cortex correlated with how loud they perceive their tinnitus. And remember, these are people that have no hearing loss. In addition to that, we did a connectivity analysis showing that actually that the break that basically is signaled by the pregeneral anterior cingulate cortex is not working that well, and that there's actually less information sent in tinnitus patients that have no hearing loss to the auditory cortex in comparison to people that have no tinnitus. So it suggests that that brake is not working that well, and that the pregeneral tinnitus cortex is not signaling to the auditory cortex to ignore basically the tinnitus or to break down the tinnitus. So this is actually a summary of all our findings, where basically if you have no hearing loss, there's more of a top-down tinnitus. And when you have hearing loss, there's probably more of a bottom-up tinnitus, but depending on how severe your hearing loss is, there's different areas involved in the tinnitus. Now, about 10 years ago, there was a new model introduced, which is the predictive coding model. Now, the predictive coding model has a different angle. The predictive coding model is actually originally not introduced specifically for tinnitus, but basically to understand how the brain is actively involved in perception. So for a long time, people were thinking that perception is a passive process, but more and more evidence is showing that actually that's not the case. And the idea is that basically the brain is constantly making predictions about what's going to happen based on previous experiences. And that we do a comparison between what we perceive and what we predict. And if there's a difference, there's a prediction error. Now, when the prediction and the input is not different, there's no prediction error, and basically the brain will not do an updating and will basically use the model that is already existing. If there's, however, a difference between what you predict and what you perceive, there's a prediction error, and the brain will try to resolve this prediction error to reduce uncertainty for future events. However, when there is hearing loss, there might be a problem. There might be a problem in the sense that what you predict is not what you perceive anymore, and that could create a problem. Now, this is the general model, and the interesting thing about this model is that we can start testing things and make predictions. So actually, Anusha did a study showing that tinnitus patients are actually more sensitive to prediction errors when we use a specific paradigm. So it seems that there might be a relationship between the predictive coding model and tinnitus, where tinnitus patients seem to be more sensitive to prediction errors. The model also suggests that actually tinnitus is becoming the new default, that's the standard. And that's probably why it's so difficult to treat, because basically this is the new assumption that you always have to hear tinnitus. Now, we're just starting to do research on this model, but there's already some indication that indeed that would be the case. Now, there's one specific area, the posterior cingulate cortex, which is part of the default mode system. Basically, at rest, the default mode system is very active in all of us, but that the default mode system is actually including the tinnitus as the new default. So when you're doing nothing, what you're hearing is the tinnitus. And we have some evidence for that, that this is indeed the case, and that basically the percentage of the time that you're hearing the tinnitus is actually driven by the posterior cingulate cortex, signaling to the parahippocampus and the auditory cortex. Now, another thing that is important in predictive coding is actually the reward system. So when we're learning, when we make predictions, if it's basically a good or a negative prediction, to adjust our model, you need to get input from areas including the nucleus accumbens, which is a really important part in our learning system. The question is it true that in tinnitus, this nucleus accumbens is more active? And indeed, we see that there's several connections that are more showing up using resting state fMRI between the nucleus accumbens and different areas all over the brain and tinnitus patients in comparison to controls. When we then did a specific analysis, what was intriguing that actually the connection between the nucleus accumbens and the parahippocampus and the nucleus accumbens and the ventromedial prefrontal cortex extending to the pregeneral tinnitus cortex actually do correlate with the time that they're already hearing their tinnitus. So the longer they're hearing their tinnitus, the more you see activity between the nucleus accumbens and the parahippocampus. In addition to that, we also showed that actually the nucleus accumbens, the connection between the nucleus accumbens and the parahippocampus is correlating with how loud they're hearing their tinnitus. So there seems to be an indication that indeed the nucleus accumbens is involved in tinnitus, which fits with the predictive coding model. Now, this is still at the initial stage, and there's several people. I know that Nathan Weiss group is doing research on this, as well as our group is doing research on this, as well as City's group is really looking into this predictive coding model because it can help us to develop new types of treatment. Now, a final model that is brand new is actually the triple network model. The triple network model tries to actually integrate all the findings that I was previously talking about. But what is intriguing is that it also tries to include other comorbidities in addition to distress, as well as try to introduce other systems like the autonomic nervous system and the cognitive system related to tinnitus. Now, again, Yasubov already introduced this, but the triple network model is actually coming from psychiatry, where you actually have a whole pathway of the steps that are happening when you have probably acute tinnitus and how it's basically is chronifying to chronic tinnitus. So the original idea is basically that there's something happening in the auditory system that creates a sound sensation that could be explained by predictive coding probably, but then basically that it signals cognitive reactions, autonomic reactions, and emotional reactions that could lead to the suffering. This is then embodied through the default mode system, and basically tinnitus becomes part of ourselves. That relates to sleep and other disabilities in quality of life that will have basically social impact that is reflected by the central executive system, and that this is basically a loop system. Now, this is a brand new model that was introduced by Dirk de Redder, but the interesting thing is that now we have a pathway that we can test in tinnitus patients to see or to confirm if actually this is true. But in psychiatry, there's already a lot more evidence suggesting that this is indeed the case for psychiatric problems, including musical hallucinosis, as well as auditory hallucinations. So this is my presentation. I thank you.